Hello, everyone. Thank you so much for joining us today. It is our November Clinical Culture and Diversity series. This is part of International Education Week, and this is, I am happy to say, the 5th annual Dr. Mani Modale Mani International Educational Exchange and Partnerships presentation. So we do have 2 more dates in our Clinical Culture and Diversity series. We will see you again in February and April. More information on those dates to come. As I mentioned, it is International Education Week, so we do have some more events this week. We hope to see everyone in person tomorrow. There's free food over in the atrium, where we will have students who went out this summer share on their international educational experiences. And then on Friday, over in the Ad Astra room, again, free food, we will have a big celebration of international education. So I hope to see everyone there. We do have a message from KUMC's Senior International Officer and the Office of International Programs on International Education Week 2023. The simple purpose of the exchange program is to erode the culturally rooted mistrust that sets nations against one another. The exchange program is not a panacea, but an avenue of hope. Senator J. William Fulbright. All exchange programs are an avenue of hope. Hope that we can gain understanding, humanity, and empathy when we sit next to, live next to, work next to, and study next to those who seem to act differently, believe differently, and live differently than we do individually. Through exchange, we gain perspective on our collectivity, on our shared humanity. Therefore, in spite of war, or maybe because of this current war and all wars, we must celebrate and promote international exchange. As Senator Fulbright, who created the Fulbright program because he knew the strongest weapon in the world was understanding and the only way to create peace, stated, we must try to expand the boundaries of human wisdom, empathy, and perception. And there is no way of doing that except through education. The essence of intercultural education is the acquisition of empathy, the ability to see the world as others see it, and to allow for the possibility that others may see something we have failed to see, or may see it more accurately. International Education Week, a joint initiative of the U.S. Department of State and the U.S. Department of Education, is part of their efforts to promote programs that prepare Americans for a global environment and attract future leaders from abroad to study, learn, and exchange experiences. According to the Department of State, International Education Week, or IEW, the second week of November, this year, November 13 through 17, 2023, is an opportunity to celebrate the benefits of international education and exchange worldwide. International Education Week is a week for celebration, a celebration of diverse cultures, languages, people, and the relationships and connections we have forged here and across oceans and continents. This is a time to celebrate our friendships and to celebrate in our collective and individual accomplishments. Here at KUMC, we know very well how much our international friends and colleagues contribute to our community and how grateful we are that they choose to work, study, or do research here at KUMC. Diversity is essential to creativity of thought and expanding our mental horizons and understandings. Simply put, we all need to interact with others who think differently and perceive the world differently, as it makes each of us better, smarter, and a little more empathetic and understanding. We know the value of individuals from around the world who come to the U.S. to study and how their presence in America contribute even more profoundly than the billions they contribute yearly to higher education. NASA, the National Association of International Educators, analysis of the 2022-2023 academic year shows that international students and their families contributed over $40 billion to the U.S. economy. This represents over $6 billion increase, or nearly a 19% increase in dollars contributed during the prior academic year. This also marks the second consecutive year of record growth following the negative impacts of the COVID-19 pandemic, which began in March 2020. NAFSA also estimates that over 368,000 jobs were created or supported during the same time frame, meaning for every 3 international students, one U.S. job was created or supported in the following sectors: higher education, accommodation, dining, retail, transportation, telecommunications, and health insurance. This represents a nearly 10% increase in jobs supported in the economy from the prior academic year. In the state of Kansas, the over 8,000 last year, international students enrolled across the state contributed over $214 million last year, and supported the over 1,700 jobs last year, 1,600. We are situated in the heart of America, and many may wonder how our international folks find their way to us. We celebrate the journey of those who come to KUMC, their presence and their immense contributions that enhance our lives every single day. International students, researchers, and employees are part of the heart of our institutions and are woven into the beautiful tapestry of American higher education and American society. Many come to KUMC through the relationships our faculty and researchers have developed over the years through collaborative, mutually beneficial programs and endeavors. We celebrate our faculty, researchers, and administrators who approach international exchange and global health with attitudes and efforts that reflect humility, inquisitiveness, and understanding. Many of our learners, 200 yearly, travel to our partner hosting institutions to learn about critical care, the strengths of other healthcare systems, and the beauty of other cultures and languages. We celebrate our learners who seek to understand other healthcare systems, social and economic health disparities, and innovative patient care from around the world. Many of our partner institutions send their learners to KUMC, participate in virtual exchange, or host our faculty and learners to exchange ideas, learn and research together, and even to share meals together. We celebrate our partners who make these deep learning experiences possible. Each one of us are part of international exchange as we are part of the KUMC community. This week is about all of us exchanging and listening and interacting together. Educational exchange can turn nations into people, contributing as no other form of communication can to the humanizing of international relations. Senator J. William Fulbright. And another fun note, we do have continuing education today for our Clinical Culture and Diversity series. If you would like it, please make sure that your name is listed first and last name in your Zoom account, so that way we can make sure we get you listed when we send the list off to continuing ed. I will also be sharing these slides in the chat, so if you don't get them right now, it's absolutely fine. And if you have questions, the lovely Kelly Sable will be more than happy to answer any questions you have about continuing ed. And we do have captions as well for anyone who would need captioning. And now I will turn it over to Dr. Sarah Kessler for some words on our very good friend, Dr. Mani Odayamani.
Okay, thank you guys. It is such a privilege to say a couple words about the late Dr. Mani, who really is a KUMC legend. And he was just an incredible colleague, friend, mentor to so many of us at KUMC. And so for those who didn't have the chance to meet him, this talk really gives us an opportunity to remember, commemorate, appreciate the impact and legacy that he has made at KUMC and around the world for that matter. Dr. Mani had an incredible mind, but also an incredible heart. And as a renowned plastic surgeon, As an educator, an institutional community leader, he touched so many lives of people in our state of Kansas, in our country, in the country of his birth, India, and in so many, really globally, so many countries around the world where he invested his time, love, and effort. For me, Dr. Mani really provided such valuable mentorship through the ups and downs in my own journey working in global health. And you could count on any conversation with Dr. Mani to inspire you, to motivate you, and always to challenge you, but to challenge you to expand your thinking, to critically reflect on your approach. But it was always with the intention to help you do better and to be better. And I feel like I would love for people here just to hear and see Dr. Mani in a brief video that was put together. It's about 4 minutes, and in it, you will instantly capture the essence of Dr. Mani. So thank you, Alexa, if you can click the video. I think you'll have to use the link. I don't know if it'll allow you to just copy that. You'll probably have to open another window. Lakeview Village is the retirement community that Dr. Mani and his wife Rebecca had moved to. And that's where the group that put this film together. If you scroll down from there, Alexa, there'll be a link. Scroll down from that image, and then click there.
Dr. Mani is not your average plastic surgeon. In the 70s, when cosmetic surgery became popular, he chose to help trauma patients.
In 1974, there was no interest in trauma. Everyone was going towards cosmetic. So there was no competition. Nobody wanted my job.
Dr. Mani was recruited from India to come to Kansas to run the KU Medical Center burn unit.
So I came on a 5-year agreement, and 5 years turned out to be 44, 45 years now.
His trauma patients faced both physical and emotional wounds. Dr. Mani worked on both, like the man involved in a welding accident.
When he got hurt on the job, we took care of him, got him well. As usual, we would say, what do you want to do when you get out? He says, anything but welding. So what are you trained to do? Nothing. Welding is my job. So we talked to him about welding for art. And if you go to Overland Park, Santa Fe Trail, and there's a circle, in the middle of the circle is a statue. Gary did that. So it is not just curing the injury, it is to get the best out of them.
Dr. Mani has kept the names of all of his patients because he held their babies, helped change their lives, and they stayed in touch with their former doctor.
And they came to the clinic, and what do you do with this baby? I said, give it to me. So I babysat when the others did all the other stuff. So that's the fun part of it. I know her name. 31 years ago, her dad was Aaron Stegmeyer.
Dr. Mani changed medical protocol too. His team approach to medicine was groundbreaking in the 70s.
Team concept in 1974 was, The nurse was considered a handmaiden of the physician. So the physician would tell the nurse what to do. Wrong. Because why would I, as a physician, tell a nurse what to do her job? She went to school for 5 years. So I don't tell them what to do. Each member of the team had an equal voice in the management of the patient.
This emeritus professor says if he could teach all medical students one thing today, it would be
Is bedside manners. Bedside manners. When you walk into a patient's room, don't stand at the doorway holding the chart in your hand and talking down to the patient. The patients are lying on a bed. Drag a chair, sit down. You're at their level. So now you are equal, not this way.
KU sent Dr. Mani and team across the state of Kansas to train doctors in any town that had a hospital. They opened a second Kansas burn unit in Wichita.
And then Dr. Robinson, my boss, my chief, said, when you're done with Kansas, plant the Jayhawk flag all over the world. So that's what we did.
The entire team set up burn units in Malaysia, Central Asia, and Australia. Travel seems to be a part of Dr. Mani's DNA, for work and for pleasure, with many family trips to Africa and Alaska.
And we trekked through South Africa, Botswana, Zimbabwe, Kenya. I've been to Alaska every year since 1975 till 2019.
Even now in retirement at Lakeview Village, Dr. Mani has travel on his mind.
I'm now talking to some people here to go to Netherlands. If you have not seen a tulip field, that's 1 acre of red tulips, 1 acre of white tulips, 1 acre of some other, you haven't seen it.
Thank you. I'm glad we got to have another glimpse of Dr. Mani and hear his words. And in that spirit of celebrating his life and legacy, I'll turn it back to Alexa to introduce our guests for today. Oh, and thank you, Alexa, for reminding me. I did have one more slide on here. This is a message that Dr. Mani would remind us of and read to us often. And he said that these words were inscribed or carved in the hospital that he was trained in, the Christian Medical College in Vellore, India. This is an institution that we partner with very closely here at KUMC, thanks to the relationships and programs that Dr. Mani put in place. But I think this really was a guiding light for him in his philosophy towards healthcare and global health, and he provided this for us. So just want to share that with you. Go to the people, live among them, learn from them and love them. Start with what they know, build on what they have. But of the best of leaders, when their task is accomplished, the people will remark, we've done it ourselves. So I'll leave you with that, and thank you.
Thank you. Thank you, Sarah. And now for our speakers that will be given the talk for us today, our good friends, Dr. Patrick Kinda and Gloria Mpanga. They're both here from Zambia. They are our guests at KUMC, completing a year of research. And this, on his third visit to KUMC, Dr. Kinda is working with orthopedic surgeon, Dr. Archie Huddins, on the African Trauma Initiative, or ATI. He received his MD from the University of Kinshasa and the Congo, and Dr. Kinda is an orthopedic surgeon at St. John Paul Mission Hospital in Lusaka, Zambia. Dr. Mpanga is working with family medicine researcher Dr. Sarah Kessler on the links between HIV and cervical cancer. She received her MD from the University of Lubumbashi School of Medicine, Lubumbashi, in the Congo in 2015. And she's a medical practitioner at the University Teaching Hospital, Lusaka, Zambia. So we welcome both of our friends today. Welcome. Tell us a little bit about what you're doing.
Okay, thank you. Okay, I think the presentation, the introduction was good enough. I'm Dr. Patrick Kinda, orthopedic surgeon and chief medical officer at St. John Paul II Orthopedic Mission Hospital. And I'm doing a fellowship program in African Trauma Initiative with Dr. Eddings. That's why I'm here in Kansas right now. And today I'm going to talk about trauma epidemic in Africa. Slide. Okay, talking about trauma in Africa, musculoskeletal trauma conditions are the most common cause of severe physical disability and death worldwide. Injuries make up a significant component of trauma globally, accounting to roughly the same number of deaths each year as HIV, tuberculosis, and malaria combined. That is according to WHO study done in 2018. Injuries also means this trauma that require also a substantial burden of global public health resources, as they are the leading cause of death among young adults aged 15 to 29 years. And Africa in particular is a continent that experiences a large burden of trauma and the highest concentration of trauma worldwide. Slide. World outside of Africa race to profit of Africa resources. Africa's own race were rapid in rise to improve the quality of life of those continents. No one has substantially invested in the healthcare system needed to treat this injury. That's occurring as a result of this rapid industrialization. Next slide. Road traffic accidents, construction and industrial accident, interpersonal violence, which include war and conflict, folk and natural calamities like earthquake and others are causes of trauma in Africa. And road traffic accident is considered to be the main one. Nearly 90% of the world's road traffic fatalities occurs in low and middle income countries, and half of those dying from road traffic accidents are vulnerable road users, such as pedestrians, cyclists. And the road traffic accident injury has been neglected from the global health agenda for many years, despite being stable and largely reviewable. Next slide. On the next slide, there is this picture I've put there. And as you can see, this is common things which we see when we're in low and middle income countries. You can see that these people travel on top of this train, means inside is fully packed. And by putting this picture, I'll just tell you a short briefing of my history. I was born in Katanga province, which is a part of DR Congo. And I grew up there. I did my primary school, my secondary school there, half of my secondary school. And it was in a hospital. It was a well-organized province, and with good school, good hospital, and everything was going well. But just halfway my secondary school, when the democracy came, because came in my country, that is in 1990 to 1994, suddenly there's this politic issue which make me know that I'm not belonging to that province. Now, there was this war, this conflict in between people originally from the Katanga province and us. We were not actually from there, but I was born there. My parents, they were born there. And for me, I was from that province. But definitely when that conflict came, now a lot of people like me supposed to travel from the Katanga province and to go to the center of the DR Congo, which is the Kasai, which I've never been there. My parents, they barely know that place, but what was said, it was said that that is our place and where we need to go. Now, a lot of people, they were traveling in this condition. And the way from the Katanga, from the camps, in a normal time, it can take only 3 to 5 days of traveling. But there are some people who made more months, 3 months, 6 months in the roads, just from living there and reaching at the place where also they are not going to be welcome. A lot of them, they died because of this condition of traveling. Why this picture it's a reminder for me, because there's one time, the time I was in the Kasai province, I traveled also in the same way, because I was at this train station waiting for the train to come. But when it came, when I went inside, I noticed that there were no space for me sitting, even putting my legs. Okay, I traveled like that from one station to the other one, but because it was very uncomfortable, because I was supposed to travel from 2 p.m. to 6 a.m. the next day. And definitely on the next station, I came out and I saw that people on top of the train, they were very comfortable. And I decided also to go there. And I traveled like that until I reached my destination. But believe me, there are too many accidents in this way of traveling, too many casualties. And people who are traveling like this, those are the people who first, they are poor, they don't have money and everything. Means even make it to the hospital, make it for surgery, that is another dream. Okay, then we can go to the next slide. Okay, now, when reaching the province where I was told that's my province where I'm originally from, now it's a battle, because you have to battle to survive. Okay, you have to battle how to go to school, how to make it, just to make to be able to eat, to have meal for the day. Now, a lot of young people, they find themselves waiting in mines. Okay, because that side we found there is too much like diamond and all of it, and there's this type of artisanal mines where youth were working in with very miserable salary, everything, but that's was the way to survive. And you can imagine that working in this condition, there are a lot of who died because it's very what you see that they have to go underground, check for to get what they are looking for, and you can see that they don't have anything which protect them, like to have all the safety protection which a miner needs to wear to go down there. And these are artisanal mines. And we can go to, and what happens when you work in this condition? We can go to next slide. The next slide is just a very short video for maybe 5 seconds, which you can see. Next slide. Okay, this is the one I was talking about as the way underground mine and everything. Now, next slide. Okay, I don't know. Okay, this, I don't know, maybe there's a small problem with that video, which showing that just when you are working in these such mines, which artisanal mines, means everything can collapse at any time. That can collapse at any time, and there are a lot of them who remain buried down there, and maybe no one will never come for them, or when you come, you are able to come out, a lot of them, they are injured. And as I said, without goods, it's difficult to make it through surgery. A lot of them, they are trader, and that's what they do. Okay, means when you are traveling inside the country, okay, inside the country, in the big city, you can have good roads, but when you are going inside, in the rural area, that's the way people travel. Okay, traders, exactly. And you can see that this is a risk. Anything can happen, and definitely you're going to have casualty there. And to fix them, it's a big challenge. We can go to the next slide. That is what happened actually in the rural area, because in the rural area, there are no roads. There are no good roads. Means a trip which you can make in 4 hours, that can take you days. And there are too many accidents. I lost 2 of my friends, which are medical doctor in such trip. And actually almost every day we have casualty in such roads. And the next slide is also showing the same. I will try to go a bit faster because of the time. The next slide is just showing also how the traffic is there. And definitely when you look at this, nothing good can come out of such traffic. And on the next slide, on the next slide, you can see that I spoke about in my introduction about there's rapid industrialization in Africa. Means there are big companies which are there, and these are trucks by the border in between Congo and Zambia. Actually, they are coming from Congo, and they are packed with copper and other minerals and everything. There are a lot of companies there, but the health system, that's the one which has been neglected. They don't invest in the health system, but every day when you are at the border, this is the situation which we face. On the next slide also is there showing us the same situation on the border. We can move on. Next slide. Yes, we can go to the next. This one also is a border, and that's the same situation. Now, out of those roads you have seen in the rural area, these are big city. You can see that there are good roads there, there are good bridge and everything. But the main things here is to follow the traffic, to respect the traffic. That's the main things there. And when the traffic is not followed, is not respected, everything's moved the way you want. And then you can find on the next slide, we can go on the next slide, you find a situation like this, where you can see that here we're in the big city, we're in town actually, you can see there are good roads, but what happened to that truck, the way it's full of people, and anything can happen at that time, then you will see this on the next slide. Next slide. Yeah, okay. These are common trader. They come usually from rural area and to do the whatever business in the city, but that the way usually those trucks, they are packed. And they move like that in town and everything, then everything can happen. Then you have too many injuries here, but the main issue is it's going to be very difficult to treat such casualty. That's why I was saying in the beginning that road traffic accident, it's a main cause of trauma in a low and middle income country. Now we can move to the next slide as just to end up my stories. As we move there, just one of the lucky one who managed to make it up to go up to my level of university and to become a surgeon and to be here today. But as you see, me and Gloria actually, Gloria is from that province where we had all these conflicts and everything. In a normal world, for me and Gloria to get married, this is it's a taboo, means it can't happen. And a lot of people, they still living in this way. But for us, being together like this means is just a way of people who we don't care about those conflicts, and that's a way we can even solve conflict, because when you are together, families can be together and everything, then you understand that we are just the same people. And everything which happened, it was just a manipulation from politics, and which was coming from actually high developed country. Then on this slide, and I say evidence from many countries show that dramatic successes in preventing road traffic crashes fatality can be achieved through concerted efforts that involve improvement of the health system. On the next slide, we are going to talk about trauma burden. As said previously, low and middle income countries faced a majority of the burden from trauma worldwide. Trauma caused substantial economic losses to individuals, their families, and to the nation as a whole. These losses arise from the costs of treatment as well as the loss of productivity for those killed and disabled by the injuries, and family members who need to take time off work or school to care for the injured one. And WHO estimates road traffic crash cost most countries around 3% of the gross domestic product. Slide. Zambia acknowledged trauma as a major cause of disability and premature death in 2013-2016 strategic plan on non-communicable disease through very little, which is less than 1% of its national gross domestic product, was allocated to the health expenditure, means 9% or $3 per capita in 2018. Moreover, out-of-pocket expenditure make up a significant proportion of trauma costs in the country. And in 2018, the total number of disability due to trauma totaled 504,000, which resulted in $738 million in economic productivity loss, means which is about 58% of economic productivity loss were to individual age 15 to 49 years. And when you have such numbers, which is recorded just by the RATSA and by government, but this is not all, because there are a lot of them, a lot who are not actually recorded. Next slide. As Zambian population is younger in age and growing in size, trauma become an even greater concern for individual and national socio-economic well-being. The population of Zambia is projected more than double by 2050 and increase 5 times by 2100, making one of the fastest growing country in the world. Apart from that, Zambia is also experiencing rapid urbanization, with 44% of people living in urban area in 2020 and projected to increase to 50% by 2035. and that will increase exposure to high-risk environment for trauma with the negative impact of early stage of economic improvement characterized by unhealthy lifestyle, increasing prevalence of unsafe transportation, excessive intake alcohol, and unsafe work environment. Next slide. In addition, the geopolitical situation of Zambia and in Southern Africa made the country extremely vulnerable to political and societal change. This risk factor drives a high burden of pressure affecting young Zambian. Okay, next slide. I'm offline. Am I back? Yeah. Am I online or offline? Are you able to hear me?
You are on, Dr. Kinda.
I'm on. Okay, thank you. Okay. Okay, we're going to talk rapidly about trauma reconstruction. Here, I just said the healthcare system in many African nations are not optimized to treat trauma. And we can see that number one, there's need of viable infrastructure and
Is that my internet or Dr. Kinda's?
Now I think he might be offline.
Dr. Kinda, you're frozen.
Because yeah, he's frozen for me as well. And I think he's been disconnected.
There, he's coming back on.
Yay!
We lost you there for a little bit. I'm not sure the internet's great where you're at, unfortunately. Sorry. We see you, but you're muted right now. You have to unmute yourself.
sorry, okay.
You're good
It's
now.
okay.
Okay. Okay, on the next slide, from this study, which was conducted by COSEXA, it shows that former accident and emergency department were present in 31% of hospital. It is on the next slide, Alexa. Are you connected? You are connected? If you're connected, I can use if you're connected. Yes. Okay. Former accident and emergency department were present in 21% of hospital. 90% of the hospital had at least one of the X-ray we use in surgery. C-arm and X-ray machine were available in only 4% of district and 27% of referral hospital. And when you are an orthopedic surgeon without C-arm, you can't do anything. Or if you don't have X-ray in the hospital, then you can't diagnose a fracture, you can't do anything. They're completely stuck. Yes, we can change the machine. Adequate instruments for surgical treatment of fracture were found only 20% of districts and 49% of referral hospital. And more than half of the referral hospital had 1/3 of, and 1/3 of the district hospital had a rehabilitation unit of patients. And without a rehabilitation unit, also you can do a good surgery, but without a rehabilitation unit, then your surgery can fail. Means rehabilitation and orthopedic surgery, they go together. And few facilities add limb prosthesis and manufacturing. Next slide. On the next slide, this is operating room, which I use in Lusaka. This is operating, I use in Lusaka with a table there, which is also a traction table, but the quality is not good. I've seen patients almost falling from this table, and compared to what is done here in KU, on the next slide, you see the operating room in KU. This is a traction table on the operating room. You can see yourself the difference. And when you don't have a good traction table, and your surgery is going to be, when you're operating, especially on lower limbs, is going to be very difficult and sometimes unsuccessful. That's the main difference. Just a table can make a big difference in your surgery. Next slide. Show you the C-arm. This is a C-arm, which is X-ray machine we use in theater, which is quite expensive machine, and you don't find it in most of the hospital. Even when they are doing orthopedic in Africa, it's difficult to find such machine. And without this one, you can't do a good surgery. And on the next slide, this is my operating traction table in theater in Lusaka, which is does good job, I can say, but I know myself that quality is not good, and you can have a lot of problem with this one compared to, next slide, Alexa, that's the normal traction table, the way it's supposed to be. That's the similar of the traction table, which is used in the KU hospital here. Okay, next slide is just the type of implant we use. I think I'll move fast from there because I don't want to take too much of the time. We can go, yes, we can go next slide, Alexa, next slide. Apart from, as I said, we need a good trauma center, there's a need of also training opportunities. The same study conducted by COSEXA, it showed that most hospitals had no general or orthopedic surgeon or medically qualified anesthetists on staff. Gross fracture treatment was offered in 7% of hospitals, although there's deficiency in X-ray machine. I can imagine how they were able to do all those closed hospital without X-ray. And the elective orthopedic surgery was offered in 29%. In many hospitals in Africa, in a rural area, general surgeon or general practitioner provide care for musculoskeletal injuries, and that clinic coverage by general surgeon is partial. Most care is provided by general practitioner and substantial amounts by nurses and other non-doctor providers. Next slide. On the next slide, there's a need of patient ability to access trauma and orthopedic services. In some cases, when both equipment and manpower are available, especially in some private hospital, there's still a big dilemma for patient accessibility to treatment. This is a place where the disadvantage of a poor take a big space. Generally, in several African countries, and particularly in Zambia, quick and good trauma services are provided in private sectors, where well-trained healthcare provider and almost adequate updated equipment are found. But where also patients with low financial income find it difficult and almost impossible to access treatment. In this institution, patient attention is based on insurance coverage or cash payment, which can be fulfilled only by a small minority of the population. And next slide. Next slide, we see also this lack of monetary resources to support the needs of local health system. And one of the main reasons there's lack of adequate healthcare system in some low and middle income countries is because of lack of money. Many institutions like where I am self-sustain themselves. I left the hospital. Before I left the hospital, about a year ago, we have our MRI machine, which went down. And up to now, that MRI machine is not, because it's supposed to be replaced. Because of the break which is there, we have to replace it. But when you have to pay workers' salaries and to cover for the disabled children, which they don't pay, and you have to pay insurances, it's become difficult for the hospital to fundraise money to buy a new machine. Next slide. This is the C-arm I use in my hospital. This C-arm has been there for years. That's the only working C-arm in the hospital. My hospital is one of the main orthopedic center in Zambia, in Lusaka. But we rely on this C-arm. And once this C-arm goes down, we need to replace it, and which require also a lot of money. But with all those challenges, it's quite difficult. Next slide. On the next slide is showing also the monitor of the same C-arm, which is actually an old one. Next slide, Alexa. Yes, on the next slide, you can see that we built a new theater at our hospital with 3 operating rooms. But here I showed you first the room which we are using, but this is an empty room, which we don't have enough funds to put equipment in this room. There are 3 rooms because we have a lot of surgery to conduct, but we are able only to use 1 room. There's this one, there's another one next to this one. They are still empty because we need to get money to put equipment in those rooms. We can go to the next slide. The next slide is showing the same room, which is empty. There's only a table. Actually, this table was purchased from the United States, but apart from this table and the good lights we have there, there's nothing else. And on the next slide is showing also the 3rd room, which is empty. You can see that we have even put sofas there. We can go to the next slide, Alex. You can see that the 3rd room, there are only sofas, and the room is still empty. And with this one, it's difficult to achieve what we want, because a lot of people like to come to our hospital because of the good outcome we offered. But definitely with all this challenge, it's difficult. Okay, I don't know if, because time is almost done. We'll talk about prevalence of trauma. Trauma represents a global public health threat which can result to injury to different parts of the body: brain, lungs, heart, intestine, spine, muscle, bones. And the prevalence of injury to these various parts of the body differs substantially, as well as the amount of resources required to treat this injury. Musculoskeletal impairment condition, which is trauma damaging bone and muscle, are the most common cause of severe physical disability and death worldwide, and it accounts for the largest amount of trauma in Africa, it was said before. Major cause of disability and premature death, according to the study done in 2013 and 2016. We can move next slide. Next slide, prognosis of trauma. Considering the amount of hospital resources required to efficiently treat these injuries, means length of hospital stay or intensive care stay, musculoskeletal trauma needs often less time compared to brain, heart, lung, or gastrointestinal trauma, and the prognosis is far much better when managed appropriately, allowing the patient to tremendously recover and return to close to pre-injury function, while despite the application of tremendous amount of healthcare resources for trauma involving other systems which save life, but does not come close to restoring pre-injury function. Next slide. Okay, these are the solutions now. We're going just to talk briefly about the African Trauma Initiative. Next slide. International Orthopedic Trauma Fellowship, with non-specialists providing much of orthopedic and other trauma surgical care continuing education courses, become an important opportunity to strengthen such care, especially at first level healthcare facilities. If we want to start in a place that is going to have a largest impact on death and disability due to the new epidemic of trauma in Africa, the best place to start is by elevating the care of orthopedic trauma. Next slide. Therefore, through the African Trauma Initiative, the International Orthopedic Trauma Fellowship for practicing surgeons from low to middle income countries is a program which tries to improve knowledge and skills of fellows during the 1-year training at KUMC, and they will return to the countries to pass on this package of knowledge to other surgeons who will be able to perpetuate this in aim to improve better care of patients. Next slide. And this program includes realistic surgical training, which is we perform on sawbone, on cadaver. There's immersive surgical care participation, which is done in actual operating room. And there's a clinical participation where fellows have to participate at least one clinic day per week, during which we discuss with the whole team about trauma and treatment. Next slide. On the next slide is just an example of what is done in the lab. This is a sawbone training in the lab. Okay, just is a model of the pelvis, but we start from this one. And next slide. Okay, it's the same sawbone. Next slide again. Okay, on the next slide, that's a cadaver practice also in the lab, means the same fracture which we saw in the operating room. We try to replicate them on the cadaver, and using the same system, CM equipment and everything, we try to fix that fracture. That's a way of learning we do. And the next slide, it's in actual operating room. We can move to the next slide. Yes, that's the actual operating room for one. And next slide. Next slide. Yeah, next slide. Okay, apart from what we do, there's also conference participation. The fellow will participate in orthopedic trauma conference, and there are also national conference and training seminar which are organized. And there's also a research where the fellow will produce at least one research paper where they become a subject matter expert in area of orthopedic trauma. We can go to the next slide. Apart from the from equipment and from fellowship program, there's also building of high standard trauma center, which is also part of the plan of the AFM. I think I'll need to. And apart from building trauma center, there's also, next slide, Alexa, there's obtaining a renewal supply of high quality orthopedic equipment, like imaging tools and implants to practice state-of-art trauma care. Means without achieving this goal, the fellowship will not be successful. State-of-art trauma care requires state-of-the-art equipment and implants. And here the hospital has to learn how to acquire implants and how to keep the stock. Let's go to the next slide. And the next slide is to enable patients to access appropriate treatment, because so that instead of to have good surgeon and good hospital, we still have this problem with patient, and is by by having partners which accompany us by contributing for the success of this program, like it has been in epidemic program, where medical treatment are given free of charge or at certain low fees for patients to access the care needed. And in conclusion, next slide, this is a collaborative program between the KUMC and African Trauma Medical School and the Mission Hospital, which Mission Hospital, actually they do most of the job of establishing hospital there, especially in a rural area, through ATI, in which we hope will improve and develop the healthcare system in many African nations to treat trauma, reduce substantially the large burden of injury and trauma-related disability and death. Also, since we are working with academic departments that train surgeons in Africa, this model can serve as a mirror in many African countries where similar training can be done either locally or regionally after acquiring appropriate training, trauma center, and a skillful trauma surgeon, which are former fellows who can train others and by this fill up the gap of disparity. And next slide. And lastly, knowing that the approach to improve healthcare system in this part of Africa, it's usually very complex. That is depends country to country and require accurate data study, acceptance from people on the site of action, and teamwork, and being aware that KUMC has now introduced global health training. It's going to be very advantageous for us to get involved in this program, the global health training, as part of our curriculum to efficiently improve our effort as leaders. I think that's all. Next slide is just showing my team in Lusaka. And thank you for your attention.
Thank you, Dr. Kinda. I want to just comment on your last 3 slides really illustrate why we asked you to give the talk for the Dr. Mani Mani Clinical Culture and Diversity Series, because it really emphasizes the educational exchange. So Dr. Mani was all about using the strengths of other countries and learning from each other. And he was completely against the medical mission model, which sends in like American surgeons to do the surgeries. They come back to America and there's no training. So this model that Dr. Headings has created with the training, the fellowship training, is in line with the vision of Dr. Mani. It's sustainable. It's capacity building. We all learn from each other. With you being here, you give a lot to the community by just being here, right? And it's also an incredibly brilliant model because it allows you to do your training on cadavers. And we all know because of visa limitations and stuff, you can't have direct patient care, but it still allows you to practice that training. I don't know if we have any questions. I would like to say, I do apologize that we ran out of time to focus on Dr. Gloria Mpanga, but we offer Foundations of Global Health talks regularly throughout the year. And so what we will do is we will reschedule for Dr. Gloria's portion here in a few weeks. And so Dr. Gloria, can you just come on for a moment and accept our apologies? I think we were overzealous and over ambitious today in the amount of material we could cover. So my apologies to you. But what would be nice is we'll focus just on you in a Foundations of Global Health talk. And we'll get with you and schedule that. Luckily, you're here, for a year, so we have time. We can schedule you that, okay?
Yeah, it seemed like he was excited to show us whatever he's enjoying in Kansas City, according to where it comes from. Yeah.
It was a great presentation, and we had such a large lead today because of the special presentation. So because it's International Education Week, we just took a lot more time with the introduction. So our apologies, but we will definitely feature you by yourself in another presentation, and everything that was presented today. Dr. Patrick Kinda did such an amazing job. I'm so glad that he gave so much information. It's a really quality presentation. So we're so grateful. Do we have any questions from anybody? Any additions, anybody? For Dr. Kinda? Okay, Maria, thank you. Actually, Maria suggested that you be our next Clinical Culture and Diversity series. Okay, Maria, that's awesome. Thank you. I appreciate that.
So Dr. Kinda, it was great to have you speak today. I have had the pleasure to be in Zambia, and so I'm a little familiar with the district and regional hospitals. For people who aren't as familiar with that system, can you maybe talk just a little bit about what those hospitals are and how people end up going to those hospitals for care?
Okay, thanks, Alexa. You mean hospital in a rural area?
Yes.
Okay, means those hospital in a rural area, as I said, most of them first they are established by missionary, means hospital who runs by church, and those are the one who does most of the job in a rural area. But the problem there is when you get an orthopedic surgeon and you send him over there in the rural area, where there is no X-ray machine, there is no C-arm, and everything, you will end up just putting plaster on patient. He can't do operation and he can't do anything. That's why most of them, when they are seen from them, and I said in my talk that most of the people who treat patients there, they are just general practitioners or they are just nurses. And after seeing those patients, sometimes they just tell them, okay, you are okay, you'll be fine, and just start doing physio while the fracture is not well reduced. And that become a problem. And that's why most of them, they come now to us, but they usually come late, okay? Yeah, they come maybe after some 3 months, after 4 months, and when it becomes really difficult to treat that patient, though we do that, but that actually happens, lack of equipment, lack of training in those rural areas, then that's bring the problem. And most of the orthopedic surgeons, they don't want to go and work from there because actually they are going to lose all the skill they have.
Yeah. Yeah. Thank you.
Well, thank you so much, Dr. Kenda. And thank you, Dr. Kessler, for your support and for everyone else who showed up today to lend support as audience. This will be available as a recording if anyone is interested, and we'll share that out. And happy International Education Week, everyone.
Thanks.
Thank
Bye,
you.
guys.